Hello, good afternoon, everyone. Thanks for coming and thanks for spending a couple of hours of your time here with us. I was invited about 5 years ago to actually talk to the same group, and I think at that time I spoke about COPD, or chronic obstructive pulmonary disease. Right now I'm going to talk to you about, of course, the lungs and shortness of breath, which is actually a very common symptom among people your age group, among the elderly, and also definitely more common in patients who have chronic lung disease. I always say that the Tri-Cities area is a very interesting area because of the Hanford site and the kind of environment that we have that unfortunately predispose a lot of us to develop chronic lung disease, especially chronic inflammatory lung disease. Okay, so we will start our discussion on shortness of breath with just the basic anatomy and function of the lung, because I think it's very important for us to know what the lungs are for. Okay, and I'm sure all of you will probably have questions like in the middle of my presentation. If it's something that cannot wait till the end of the talk, just raise your hand and I will repeat the question as you ask me. In that way, it's also recorded, and I will try to answer it as best as I can. But I would prefer that we reserve our questions at the end of the talk, if that's all right. Okay. All right. So the main objectives for today really is to define what shortness of breath is, identify the disease processes associated with shortness of breath, and also identify conditions, not necessarily just lung conditions, that can contribute to that. I would also like to have some sort of review of the steps we can take to help alleviate our shortness of breath, especially, as I've said, in our age group. I'm including myself there. I'm older than I look. Okay. All right, so this is the respiratory system, and the respiratory system actually starts with your nose, and it goes all the way down into the smallest air sacs that we have in our lungs. The main purpose of the lungs and the respiratory system is, of course, to provide us with oxygen, which is the necessary fuel for our cells to function as they should. Another function of the respiratory system is for us to actually exhale carbon dioxide, which is the metabolic byproduct of the different functions of our body. So we, in fact, inhale air, get oxygen from the air that we inhale, and then in exchange, the blood that actually surrounds our lung sacs expel carbon dioxide in exchange for that oxygen. So that exchange is very important. So the upper airway, so the respiratory system is randomly divided into the upper airway and the lower airway. The upper airway is comprised of our nose, our sinuses, the mouth, the pharynx, which is essentially the back of your nose, your back of your mouth, and the larynx, which is the area where your voice box is. The respiratory system is also enables us to talk and also to sing. The sinuses actually play a very big role in the quality of our voice, whether or not it's good or bad, I guess, and whether or not we can participate in the choir. So that's actually very important. The lower airway starts from the trachea, which is your windpipe, and goes all the way down into the smaller airways, the bronchi, the bronchioles, and then the air sacs where the magic of oxygen and carbon dioxide happens. Okay, so the nose and the sinuses, they're responsible for moistening the air that we breathe. They heat and clean the air that we breathe as well. So the nose and the sinuses really are the first line of defense to anything, larger than probably several microns that we breathe in. So that's why we sneeze. It triggers certain reflexes in our nose and sinuses to expel those larger particles. The epiglottis is a soft tissue structure in your throat that serves as a gate. It closes off the voice box to food and other particles meant to be swallowed. A lot of the times as we become older, this also becomes dysfunctional. And so there are times when we actually end up coughing more when we eat, or we actually choke on our food. Okay. The voice box is responsible for phonation, meaning for talking, for singing. And it also protects the trachea because it also acts as a gate. It sort of adducts and abducts. It opens and it also closes. The trachea is the windpipe, which is the largest part of your airway, and it splits into the right and the left main stem airways, or bronchi. From the bronchi, the larger airways become smaller airways, and they're called bronchioles. They're respiratory tubes that bring air into the alveoli, or air sacs, where the exchange of oxygen and carbon dioxide happens. So this is just a picture of what the air sacs look like. So these are your smaller airways, and the smaller airways are called terminal bronchioles, and then it becomes a respiratory bronchiole. The respiratory bronchiole is attached to the air sacs, and the air sacs actually are enveloped by small blood vessels. And the small blood vessels are the ones responsible for getting oxygen into our system and getting carbon dioxide out into our lungs and up and out, and that's why we exhale. Okay. There are certain diseases that affect, every part of your respiratory system. The big airways, the smaller airways, the air sacs, and also the smaller blood vessels that surround the air sacs. Okay. This is a cross-section of your lungs, and the lungs actually so the lungs are groups of air sacs, right? They're attached together and they're held together by this small film of lining. It's called the pleura. And the pleura actually is one of the two areas in your lungs that actually have pain fibers. So whenever you get pleurisy, that means inflammation of your lining of your lung, you will feel pain along the chest wall. The other site that has pain fibers would be the larger airways, the trachea, and the bronchi. And you can feel, some pain and discomfort there whenever you have a bronchitis or inflammation or infection of the lungs. But the lung tissue per se actually do not have nerve endings, and they do not feel pain. Part of the reason why I also included this section is because right in the middle of the lung is also the heart, which is a very important organ that participates as well in delivering oxygen and getting carbon dioxide out of the body by acting as a pump. So the heart is a pump that's necessary for life, that drives blood to our essential organs. And whenever there's something wrong with the heart, the lungs are affected, and you will feel shorter breath when there's something going on with the heart as well. Okay. So this is just a basic anatomy of the heart. The heart is separated into the right heart and the left heart. The left heart is the one responsible bringing oxygenated blood into the rest of your body, so blood that has oxygen that needs to go to your brain, to your kidneys, to your intestines. The right side of the heart is the heart it's part of the heart that's connected directly to your lungs. And everything actually is essentially connected to each other. And so when there's something wrong with the left side of the heart, that gets reflected back onto the right side of the heart, which then gets reflected onto the lungs. This side sort of shows us what happens to the heart that have started to age. So the muscles are a lot thicker, they don't pump as well. The arteries that supply the heart also develops plaques, and in certain people get enough plaque buildup and actually clotting that they develop heart disease or heart attacks. Okay, so the aging lung. So before we jump into shortness of breath and what it is, I'd like to describe certain changes that happen to our lungs as we become older. When we reach the age of 25 years old, our lung function actually starts going down. And this is true for everyone, whether or not you have asthma or COPD, or you're normal and you're healthy and you don't have, you're not on any medications. That's just the normal, that's just a fact of life. And part of it, I think, is because of the fact that the lungs is essentially exposed to the environment. It encounters bacteria and viruses, dust particles, chemicals, and it has to protect itself and protect the rest of your body from the harmful environmental exposures that we deal with from day to day. And so that's part of the reason why lung function rapidly, well, I shouldn't say rapidly, but does decline as we start growing older. Okay? A large part of the aging process affects the spine and the muscles. They say that by the age of 40 years old, we actually start seeing changes in the curvature of our spine. And when that happens, it actually narrows the space between our ribs, and it actually decreases the amount of space where your lungs can actually expand. They did studies and they found that the curvature, we call it kyphosis, where you sort of become stooped or hunched back. We found that women tend to have a more rapid progression of this curvature of the spine. And when that happens, when it reaches a certain degree angle, so at around more than 40 degrees, then you start developing symptoms of shortness of breath just because of the fact that your chest cavity doesn't have enough space. Okay. As I've said, the angle increases more rapidly in women, and it's also related to a reduction in your lung function. Your FEV1 is your lungs' ability to blow out air in 1 second. And for those of you who have done pulmonary function testing in our lab, this is when they ask you to exhale as much as you can, as quick as you can. Okay? All right. The other thing that happens whenever there's rib space narrowing because of the kyphosis is that it decreases the length of your rib muscles, and with that, it also decreases the movement of your ribs. The ribs participate in breathing, especially whenever you have chronic lung disease like COPD or chronic asthma. As we become older, it's not just the diaphragms that help us breathe. The diaphragm is a major muscle of respiration. But as we become older, we try to recruit other muscle parts in our upper body, like the intercostal muscles or muscles between our ribs, to help us breathe better. And that's why, later on, I will discuss the importance of actually strengthening your upper body muscles, because these are the muscles that would help you breathe better as you grow older. Okay. As a result, aging essentially results in inspiratory and expiratory, respiratory muscle strength deterioration. So your muscle strength within the intercostals also decrease. Okay. They also found out that the muscles of the elderly has less ability to handle metabolic demand. So meaning if you become sick with a respiratory infection, develop pneumonia, the muscles a lot of the times cannot keep up with the demands of the body, and then you develop respiratory failure. Respiratory failure means the lungs cannot provide enough oxygen for you. You'll need to, put on some oxygen while you're acutely ill. Okay. So this is just a statement that I found that best summarizes what I just talked about. If an elderly patient becomes ill with pneumonia and has increased metabolic demands for oxygen in the setting of decreased respiratory muscle strength, decreased cellular energy reserve, decreased overall muscle function, he or she may not meet these demands, which leads to increased risk for respiratory failure, being on the ventilator, being admitted to the ICU, and also their sense of shortness of breath will also increase with that. Okay. Another phenomenon that happens in the aging lung is that our ability to clear mucus from the lungs go down. There are lining cells in the airways that are responsible for producing mucus and also clearing mucus. Mucus is actually good. Phlegm is actually good because what it does is it traps the mucus, it traps the organisms, the viruses, the bacteria that you inhale, and what it does is it tries to bring them out. there are little hair cells on top of these mucus cells. There are little hairs that beat up and try to get the mucus out. That's what we call the mucociliary elevator. And we call it an elevator because these cells' purpose is to get the mucus and anything that's trapped in it up and out of you. Okay. All right. Part of the reason why that we're unable to clear our mucus effectively when we become older is because our cough reflex goes down. Because of the fact that our muscle strength goes down, our ability to get a big inhale in and a big exhale out to expectorate also goes down. Okay. And the mucociliary elevator in itself, the cells responsible for getting the mucus out, also tends to become sluggish as we become older. So that's another important thing to remember. Okay. So this sort of just summarizes what I said about why it's difficult for us to cough and expectorate. Our muscles decrease in strength. There's a decrease in the cough strength. And then there's an impairment in the mucociliary elevator function, and that results in poor airway clearance, where we cannot get the mucus or whatever it is inside our lungs effectively out. Okay. This is sort of an interesting process. There's such a thing as inflammaging. They call it inflammaging. It just means that as we become older, our baseline inflammatory chemicals in our bodies actually go up. They really don't know why, but they've studied people older than 65 years old. They took their blood and they've tested the levels of inflammatory chemicals in the body, and they found that the elderly have more inflammatory chemicals in the body than normal. These pro-inflammatory chemicals actually can be harmful to you and to your lungs because it may break down the parts of your lungs that make them elastic, and it also prevents you from mounting an appropriate immune response against infection. What I also found interesting in my readings in the aging lung is that you know how we have baseline issues with sometimes remembering and recall as we grow older. There are people who have dementia. The cells of our immune system apparently also get some form of dementia, where they forget that they've already encountered that bacteria or virus. And so when you get sick again, instead of remembering and mounting an appropriate immune response so that you don't get sick anymore, the cells actually forget. And so you get as sick as you were the very first time you encounter these bacteria. And so I found that really interesting. So the two terms that we have to remember is the inflammaging, meaning as we become older, the levels of inflammation in our body is just higher than normal, which prevents us from mounting an appropriate immune response and also destroys certain parts of our body, especially our lungs. And what we call immunosenescence, where I call it just like immune cell dementia, where the cells are responsible for protecting our system from bacteria and viruses just become forgetful, like us as we become older. Do we have any questions for that section of the talk? Yes, sir.
Do you have any good news for us?
So the good news will come at the end. Yes, ma'am.
So if we're going to have dementia in our lungs, why would we want to get shots?
Okay, so the shots really are the shots are vaccines, right? That's what you're talking about. So the flu vaccine or the pneumonia vaccine. So the flu vaccine and the pneumonia vaccine actually provides, I should say, a low-level chronic stimulation of your immune cells so that it doesn't forget. Specifically for the flu virus and the pneumonia bacteria. Yes, but unfortunately we do not have vaccines for every single bacteria or virus that we encounter every day. And so we get what we can. Yes, sir.
Yes, could you just why you don't want it.
Okay, so we have a question here about pulmonary hypertension, which is a kind of pulmonary disease. So I will just give a quick summary of what it is. It is one of those medical diseases, medical issues that will give you shortness of breath. So recall the right side of the heart, right? So I told you earlier that the right side of the heart is connected to the lungs. Pulmonary hypertension is actually a general category for any disease that will increase the pressure of the right side of the heart and increase the pressures of the pulmonary vessels surrounding your lungs. It causes shortness of breath because of the thickening of the blood vessels surrounding the air sacs, which prevent appropriate exchange of oxygen and carbon dioxide. It also causes bad effects on the left side of the heart, where the right side of the heart, if it becomes really big and if it develops very high pressures, actually pushes on the left side of the heart, which is responsible for bringing oxygenated blood into different parts of you. And that becomes an issue as well. So it causes shortness of breath mainly because of the inability to extract the oxygen from those thickened blood vessels surrounding the lungs, and also because of pressure changes within the lung interstitium and the blood vessels. All right, okay, so I will move on. Oh, yes. Yes, sir.
You said at the very beginning that there's something unfavorable about this environment locally. What is that?
So our gentleman here is asking about what's unfavorable about the current environment here. So that is mostly because of the allergens that we have in the area. There are a lot of people in this area who have bad asthma and allergic rhinitis that can affect the lungs. And if asthma becomes uncontrolled, it essentially becomes like COPD or chronic obstructive pulmonary disease, a more chronic pulmonary issue that results in shortness of breath all the time. I will discuss a few points about asthma and chronic obstructive pulmonary disease as we go on, but it's mostly the antigens, the dust, the pollen in the area. Yes, yes sir. Yes, yes. So there's a question here about choking and swallowing and what it has to do with the lungs. So as you know, when you choke on food or fluid, that means that food particle or that a small volume of whatever you've drank have gotten into your lungs. And if that happens chronically, meaning if that happens on an almost everyday basis, it actually incites inflammation in your lungs and then can actually cause lung fibrosis, certain types of lung fibrosis. And another thing that may cause is recurrent infection or recurrent pneumonia. And as we grow older, our ability to actually swallow appropriately and get the food into the food tube or esophagus becomes sometimes difficult for certain people. That also has something to do with certain neurologic diseases that can happen in the elderly, like strokes or advanced dementia or Parkinson's. Okay. All right. Okay.
I would like to say something about that man earlier. It said, all the bad news. Why don't we just look around here and see everybody that's got lung disease and how well we are treated? There's two sides to the story. The bad side is you don't take care of yourself, and the good side is you are partially responsible for giving us excellent medical care. And that's sad.
Thank you, sir. So that was, I don't know if everyone heard that, but the gentleman out there just said that there is good news, and there's another part of the story where people who have chronic lung disease actually get appropriate and good medical care in this area, and I appreciate that. Thank you. Okay. All right. Okay. So what is shortness of breath? Shortness of breath is, first of all, it's a subjective experience. So my sensation of shortness of breath is different from your sensation of shortness of breath. The intensity of the sensation of shortness of breath is also different from one person to the other, depending, of course, on the severity of their illness and also their state of mind. So the psyche also plays a big role in our perception of shortness of breath. So shortness of breath really is a consequence of interactions of the brain, the different parts of your cardiovascular system, your heart, the lungs, the respiratory system, the airways, and even your kidneys, the amount of fluid in your body, the amount of sleep that you've gotten, whether or not you're depressed, whether or not you're anxious. So all of those actually contribute in the sensation and in the perception of what shortness of breath is. Okay. So there are certain conditions that result in shortness of breath. And I'm not talking about a regular, normal individual who are not on medications and who's healthy. People who have increased stiffness in their lungs, and these people are those who have heart failure, who have lungs that are filled with fluid. People who have pulmonary fibrosis, where the lungs are filled up with scar tissue and inflammation. They tend to have more shortness of breath with usual activities than normal people. People who have deconditioned and weakened muscles, people who have paralyzed diaphragms. So as I've said, the diaphragms are the major respiratory breathing muscles that we have. There are certain conditions that paralyze the diaphragm that can result in shortness of breath. People who have severe enough kyphosis, the hunched back, the people who have a spine that's sort of bent sideways. They have what we call neuromuscular respiratory illnesses, where it's really the muscles and the nerves that prevent them from breathing normally. Okay. People who have COPD can have shortness of breath, not just because of low oxygen levels, but also because of high carbon dioxide, which tends to happen in people who have COPD. They cannot exhale as much as they can, and so their ability to expel carbon dioxide, which is the byproduct of metabolism in the body, tends to be lower than normal. And so when your carbon dioxide is high in your blood, your brain senses that, and it tells you to be short of breath. It's sort of a protective mechanism. Okay. People who have asthma. People who have asthma have airways that are very sensitive and actually decrease in size and caliber. And when that happens, you will feel shortness of breath because air cannot get in and air cannot get out as well. So I spoke about heart disease and respiratory disease being connected to each other and manifesting with both shortness of breath. So people who have heart failure, those who have hearts that don't pump as effectively as normal, people who have very high blood pressures and heart that cannot overcome that high blood pressure, they can actually develop pulmonary edema. Pulmonary edema is a medical illness where you develop boggy lungs. So your lungs essentially fill up with fluid just because of high pressures on the left side of the heart, which then reflects into the right side of the heart and then into the lungs. Apart from the shortness of breath, you can also develop leg swelling, chest tightness and chest discomfort, and also cough with pink frothy sputum is how we traditionally describe the cough of people who have heart failure. Okay. People who have COPD and chronic obstructive asthma can also develop hyperinflation, where the lungs are just blown up like a big balloon. Because the main issue with COPD really is inability of the lungs to exhale out as much as you can. And so you develop hyperinflation. So imagine your lungs like a blown up balloon and try to breathe with your lungs blown up like that. So you will feel short of breath when that happens. Okay. There are certain people who actually have muscle metabolism issues, and these usually happen in younger individuals. A lot of these are genetic. So people who have, in the extreme of things, muscular dystrophy, they can have shortness of breath just because of their muscles' inability to process energy and also to move as expected because of their genetic deficiency. Acute anxiety or fear actually also increase your shortness of breath. what happens is that whenever we're anxious, there's an abnormality in how we process sensory data, and so we feel more short of breath more so than usual. And then what happens is we hyperventilate. We breathe at a very rapid rate, and when that happens, we essentially trap air, and we also hyperinflate, and then we become short of breath. Certain people who also have fibromyalgia or depression may also have a heightened sensation of shortness of breath as well. Okay. So these are just the descriptors. So a lot of the times people say, oh, my chest is tight, it feels like my chest is constricting. That can happen in people who have asthma and heart failure, and that's because of bronchoconstriction, which is the airways decreasing in size, and for heart failure, interstitial edema, where the lungs just actually fill up with fluid. People, as I've said, who have COPD, asthma, neuromuscular disease, they can have shortness of breath because of airway obstruction and inability of the muscles to work as good as they should. People can have a sensation of air hunger, and those who have chronic clots in their lungs or heart failure, they also can have a sensation of inability to get a deep breath in, which especially happens in people who have hyperinflation, where just air trap cannot get any more air in. And then there's also a sensation of heavy breathing, rapid breathing, and a lot of the times when we investigate, it's really because of deconditioning. So people who just haven't exercised on a regular basis or who are carrying more weight than usual can also have shortness of breath. Okay. So these are the common diseases associated with shortness of breath. There are actually a lot more than this, but this is what we normally encounter on a day-to-day basis in clinic. So asthma. Asthma is an airway disease where you get episodic and intermittent shortness of breath and coughing and wheezing because of certain stimuli, whether or not it's allergies or other types of environmental triggers. This is different from COPD. So chronic obstructive pulmonary disease is more permanent than asthma in a sense that you're short of breath most of the time and not just during periods of attack. And COPD is mostly because of environmental exposures to certain chemicals, and also, the most important thing is smoking. So it's smoking, and then, for people who have worked out in Hanford who have had exposures to certain chemical fumes, those can cause COPD as well. Interstitial lung disease or pulmonary fibrosis is a separate disease group of the lungs where the main issue is thickening of the lung tissue itself that prevents oxygen and carbon dioxide exchange. There are several different types of pulmonary fibrosis. That's sort of just a general umbrella term, but the main pathophysiology, meaning the main mechanism, is thickening of the lung tissue. Okay. Pulmonary hypertension is another disease entity that can cause shortness of breath. It's more common than what we think it is. It's caused by an elevated pressure on the right side of the heart and elevated pressure within the capillaries and blood vessels surrounding the alveolar sacs. There are different types of pulmonary hypertension, but the main process is essentially the same, or the main mechanism is the same, and that blood vessels around the air sacs thickened, and there's an inability to exchange oxygen and carbon dioxide with that. Okay. I should say that pulmonary embolism, which is developing a clot within the blood vessels in your lungs, can also cause shortness of breath, and typically it's an acute shortness of breath associated with chest tightness, and a lot of the times it's also associated with clots in the lower extremities. Congestive heart failure is a disease of the heart where the heart stops pumping as good as it should, and when that happens, you develop pulmonary congestion, where the blood that should be going out into the system actually builds up and ends up in your lungs, making you short of breath and making your oxygen levels actually low. Okay. If you have an arrhythmia, so an arrhythmia is an abnormal beating of the heart, whether or not it's atrial fibrillation, atrial fluttering, that can cause shortness of breath. Because whenever your heart is not beating in a normal pattern, blood flow also is not normal. Blood flow, instead of moving forward, moves back into the right heart and then into the lungs. And then you get signs of heart failure too, and then you get short of breath. Okay? Cardiac ischemia is like having a heart attack. So if you have blood vessels in your heart that's preventing blood flow into the heart muscles, you'll feel chest pain and shortness of breath. So it's also important to make sure in any of you who have shortness of breath that an underlying cardiac disease is also ruled out. Okay. All right. Sleep. So I put in obstructive sleep apnea. I think that obstructive sleep apnea is certainly underdiagnosed in your population, in every population really in general. So obstructive sleep apnea is a phenomenon where you actually stop breathing at night because of the upper airways becoming floppy, your pharynx, the back of your throat becoming floppy, and you actually have periods of no breathing at night. That wakes you up, and when you wake up, you're like, oh, I need to go to the bathroom, and then you go back to sleep. But that happens multiple times through the night. And sometimes, even if you don't get a sensation that you're fully awake, you actually get what we call microarousals, where you're awake but not awake enough for your brain to know that you're awake. So it's important for you to actually, if you have concerns, usually it's the men that we see because the wives complain about their snoring. But if the husbands actually hear their wives snoring and stopping breathing at night, don't think it's rude to tell their doctors that your wife is snoring. It's okay, because sleep is a very important aspect of your day-to-day and how you feel during the day. So if you're not getting adequate sleep at night, whether or not it's because of sleep apnea or insomnia, if you have, you're thinking about the kids and the grandkids and you're worried, then the next day will not be good for you. If you have chronic lung disease or chronic heart disease, the next day will always be more difficult and you'll be more short of breath. Okay. People have anemia. So anemia is essentially having abnormal blood levels or having low blood levels. Anemia contributes to your energy level during the day and also your shortness of breath, because anemia is when your hemoglobin goes down. Hemoglobin is a chemical found in your blood, and hemoglobin is responsible for taking those oxygen molecules and bringing them to your muscles, to your brain, to the different parts of your body. So if you have anemia, you will be short of breath. And of course, it's important to find out where the anemia is coming from, because in this population, cancer is also common, and anemia can be a main manifestation of cancer, especially colon cancer. Okay, so make sure you get your colonoscopies, and if your blood count is low, to remind your doctors to ask, well, why is my blood count low? Is it just because of diet? Is it just because you don't like eating meat? Or if you have blood actually coming out of your stool and you don't know about it. Yes, ma'am.
Is there an association between anemia and low blood pressure?
Is there an association between anemia and low blood pressure? So there's no direct correlation between anemia and low blood pressure, just because when you're anemic, your body tries to compensate for that by producing more blood volume. So there's a cellular component in your blood and there's a plasma component. So when you're anemic, the plasma component goes up. So it makes your blood pressure normal. If you have acute anemia where there's blood loss from a gunshot, or suddenly your colon just perforated, then there will be low blood pressure associated with that. But with those with chronic, long-standing anemia, usually the blood pressure is normal. Okay. Yes, sir.
The medications for blood pressure and rhythm and those kinds of things in treating heart conditions, are the medicines ever contributing to shortness of breath?
So the question is whether or not there are medications out there for blood pressure and the arrhythmias and rhythm of the heart. Can they contribute to shortness of breath? So when you take a look at the adverse effects of these medications, usually what you will find is fatigue. So just not feeling good, not feeling energetic, not necessarily shortness of breath. However, there are certain types of medications that can affect your lungs directly, resulting in inflammation and fibrosis of your lungs that will give shortness of breath. A lot of the times, they talk about metoprolol. Does anyone, how many of you are on metoprolol? Metoprolol is a very good blood pressure medication, but they say that it can affect the lungs, it can affect people who have COPD and asthma, but they've actually done studies on this. Unless you're taking 200 milligrams of metoprolol every day, it should not affect your airways. I know that there used to be an old saying where, well, if you have asthma or COPD, you can't have metoprolol. But they've proven that it's okay to have metoprolol. That's actually a very good medicine for people who come in with heart attacks as well. So in patients who have COPD or asthma and who have had heart attacks, putting them on metoprolol, even though it can potentially affect the airways, actually resulted in better outcomes than not giving them the medicine. Yes, ma'am.
Is that a term that you use? I didn't catch the name of the medication. Is that a beta blocker?
Yes, it's a beta blocker.
Is it the LABETALOL? The beta blocker?
So,
That's what I take.
That's also a beta blocker. So everything that has a lol on the end usually are beta blockers.
I hate them. They make you feel like I'm walking through molasses. But you say it's not too bad in stressing out the lungs?
It's not too bad in stressing out the lungs. Yes, they've done studies on that, but what it does give is fatigue, and that's why you feel sluggish when you're on it.
I hate it.
Yeah. Okay. All right.
Thank you.
You're welcome. Okay. So another condition that can give rise to shortness of breath is weakened and deconditioned muscles. So it's winter is coming, right? So we're a couple of months away from heavy snowfall. Although I heard they're predicting a warm winter these days. But whenever we don't do anything, when we're just on our couch or on our recliner watching TV all day, if we do not get up and exercise those muscles, we will be more short of breath. And it's because your muscles have to be conditioned by activity. Your muscles actually have memory. And it seems like dementia and forgetfulness seem to be the theme of our talk today. But your muscles forget. Your muscles forget if you don't move them. And so it's like relearning things all over again. And when the muscles relearn things and try to move and try to use, the sources of energy that's provided to them, it sorts of gets shocked. And they're like, well, I'm not used to this. I'm going to tell your brain that you're short of breath. And then it prevents us from moving more the next day. I'm sure a lot of you guys have exercised, tried to exercise, the next day you feel sore. And the soreness really is a sign that your muscles are working and that it's okay to challenge the muscles again the next day or the day after when you're feeling a little bit better. But the one thing that you don't want to do is to just stop because of the discomfort. Arthritis is a totally different issue. So what I'm talking about is the normal aches and pains that we feel when we try to exercise. If you have arthritis and the joint is painful and is swollen, that has to be addressed. That's going to make your life trying to exercise more difficult. And so that's why I should have mentioned that pain too has a role in shortness of breath. Because the more pain you feel, the more short of breath you become. Because you really are using more muscles than normal when you're in pain, especially when you have pain in the lower back or hips. You use certain muscles in your body and in your torso to compensate for the pain and the movement that you're doing so that you can achieve what you need to do. And that means using more muscles. And when you're not used to using that amount of muscles, you will be short of breath. Okay. Next is malnutrition. And in the Western countries, malnutrition in the form of obesity is more common than malnutrition than we see in the third world countries where you see babies emaciated and all that. It really is about maintaining the weight that you're comfortable with. And I know that there are a lot of dieting fads out there, but the most important thing is to just eat healthy portions, less carbohydrates, more protein. If you don't have kidney failure, we shouldn't eat too much protein if we have underlying kidney failure, and more of the good fats. So good fats, avocados, sardines, salmon, and even eggs. Eggs are okay now to eat. Butter is better than margarine now. I know 40 years ago, butter is a no-no. And I'm more of a proponent of everything in moderation. And I think when we combine a good diet and appropriate exercise, that reaching that ideal weight for you will be possible. The ideal weight for one may be different for another person. So it's best to talk to your physician about that. I usually am not a proponent of giving diet pills because a lot of the diet pills may actually affect your heart and your lungs. And so if you can do it the natural way, that would be best. There are certain metabolic issues too that contribute to not being able to lose weight. People who have thyroid issues. That's one thing also that needs to be addressed as in the efforts of trying to lose weight. All right. Any questions? Yes, ma'am.
How much of an adverse impact does GERD or gastrointestinal reflux disease have on the lungs and heart?
Okay, so the question is, what is the extent of the impact of uncontrolled reflux disease there is in the lungs or the heart?
Yeah.
So uncontrolled reflux is certainly a concern. It can actually exacerbate chronic lung conditions. So COPD, asthma, one of the big exacerbators of COPD and asthma would be uncontrolled reflux. And that's because the acid, especially at night, can go up your esophagus, into your airways and into your lungs, and can exacerbate or aggravate the already chronic inflammation in your lungs. There are also studies out there, if you talk to the people over at the University of Washington, they've associated uncontrolled reflux with the development of pulmonary fibrosis. And so there's a big study that has been going on for a while, and they're taking people who have pulmonary fibrosis and reflux, and they're trying to treat the reflux by surgery. And they're trying to see whether or not that will help with the progression of the pulmonary fibrosis. So the two are certainly connected. It may not be directly correlated to uncontrolled heart disease, but certainly with the lungs, there is a connection. Okay, I guess we can proceed. Okay, so so we've been talking about shortness of breath and the conditions that cause shortness of breath. I wanted to focus on, apart from shortness of breath, what other symptoms should I pay attention to? And when should I be calling 911? When should I be heading to my doctor? Okay, so change in your vital signs. If you're a patient who wears oxygen on a normal basis and all of a sudden you're short of breath, and you're noticing that your oxygen levels by saturation, there's a little, portable oximeter that you can buy actually. So when you notice that your oxygen saturation goes down together with the shortness of breath, despite being on oxygen, then that should mean you should call someone, either your doctor, your primary care doctor, your pulmonologist, or 911. Okay. When your blood pressure is low, when you're short of breath and you're getting lightheaded, you're dizzy because of low blood pressure or because of the fact that your heart rate is through the roof, despite resting, then that's also a sign that you probably should seek medical attention. Okay. As I've said, if rest does not make it better, if you have chronic lung disease and you've used your nebulizer, your rescue nebulizer or your rescue inhaler, and after 5-10 minutes you're really just still huffing and puffing, then it's also time to give your doctor a call or call 911, especially if there's chest tightness that won't go away that's associated with the shortness of breath, or a sense of chest pain that radiates to the back. That's certainly something that's concerning. Okay. All right. So in the healthy elderly, how can we prevent shortness of breath? So a lot of us here in this room have chronic lung disease and chronic heart disease. So it's important to be compliant with our medications. Your inhaled therapy, so for people who have COPD and asthma, you are supposed to be on a maintenance inhaler and a rescue inhaler. The maintenance inhaler is, of course, for maintenance, meaning it's something that you have to take every single day no matter what. And the purpose of these maintenance inhalers is to really decrease the chronic level of inflammation in your airways and in your lungs, okay? The rescue is there to help with bronchoconstriction, with the airways tightening up. The albuterol or Duoneb, ProAir, Proventil, they're designed to make the muscles, the smooth muscles of your airways, to relax and open up whenever you're having an attack or whenever you're just being exposed to antigens that can be irritating to you. Okay. For people who need oxygen because their oxygen levels become low, whether or not it's because of emphysema or pulmonary hypertension or pulmonary fibrosis, it's important for you to wear your oxygen, especially if your oxygen saturations drop to 88% and below. And that's why when you come into my clinic, I always ask, do you monitor your saturations? How low do they go down to? Are they associated with shortness of breath? Or do they just come on randomly? If it's at 88% and below, it's important that you use your oxygen. Okay. Blood pressure and heart rate controlling medications are important to take because, as I've said earlier on, the heart is closely connected to the lungs and is related to the lungs and shortness of breath. And if the blood pressure is uncontrolled or your heart rate is at 160, you will feel short of breath. Your diuretics, your medications that help you urinate, that helps decrease the amount of fluid and salt in your body. Remember, if you're carrying extra weight because of fluid and extra salt, you will be short of breath. And therefore, it's important to maintain what we call euvolemia, meaning just a normal level of fluid in the body. Usually, you know when you need to take your diuretics, when you notice swelling of the legs, or when you notice that when you're laying down, you can't lay flat anymore, you have to sort of sleep propped up. So those are signs of heart failure. And that means that you have to make sure that you go back to your diuretic, or if the diuretic's not enough, that you notify your doctor about it. Okay. Blood thinners. Blood thinners are important for people who have had a history of clotting in their legs, in their lungs, and also in people who have atrial fibrillation. So for those who have atrial fibrillation or irregular heartbeat, the anticoagulation or the blood thinners is important to make sure that you don't develop any strokes. Okay. There are people who had developed chronic clotting in the lungs, and it's important for them to be maintained on anticoagulants or blood thinners. Okay. Exercise. So exercise is something that we all need to do. I see a lot of patients and they say, oh, well, I'm active in my house. You know, I do the dishes, I go down and do the laundry. Exercise is separate from the day-to-day chores that you do. You have to dedicate a certain amount of time during the day for yourself to actually walk and concentrate on moving the larger muscles of your body, because that will really help with the shortness of breath and reconditioning yourself and the rest of your body so that you're not impaired all the time. Okay. For people who have COPD, for those who have chronic asthma, for those who have pulmonary fibrosis and even pulmonary hypertension, there's pulmonary rehabilitation. So it's a program that we offer over at the Healthplex. It's usually paid for by Medicare. And you spend no money for 8 weeks of intensive physical exercise and as well as education and teaching. So that's a service that Kadlec Healthplex can offer you. There's also cardiovascular rehab for people who have had heart attacks or heart failure that they can participate in, also at the Healthplex. Okay. Physical therapy for those people who have had injuries to their knees, to their, to their back. For those people who have had issues with balance, physical therapy is essentially, very important in regaining that sense of balance and strength in your muscles. And that way you don't get short of breath and you actually get started in an exercise program. Okay. A good diet. So I heard that in the pamphlet that was given to you, you were given a list of certain foods that can help with your lungs in general. And so I'm not very strict in saying, well, you can't eat this, you can't eat that. Really, the rule is limit the amount of carbohydrates that you eat. So there are a lot of meat and potato guys around here. I guess it's because of the area. So limiting the potatoes, eating more of the meat, less of red meat. So white meat will be chicken, turkey, pork without the fat. You can have a little bit of fat here and there. But not 5 pounds of bacon, please. I used to have a guy, I had a patient that ate 5 pounds of bacon every week. We're down to 1 pound, so that's good. So just choosing the food appropriately and limiting your portions. So I always tell my patients who have COPD and who have little lung capacity to eat more than 3 times a day, meaning to cut down your meals to smaller meals and spreading it out through the day. And that way, because what happens is, when you're full and your stomach is big, that actually pushes up into your lungs and you feel short of breath. And so if you cut down the amount of meals that you eat, but increase the frequency, you can still get enough of the nutrition that you need through the day, but then not have the sensation of feeling short of breath immediately after your meal. Another thing that happens after a big meal is that we all become sluggish, right? Yeah. So, and that's because of blood flow. Blood flow goes all down into the stomach, and then there's not much blood flow to the brain, and we become sleepy. So it's always good, especially in this age group, to decrease the serving portions, but then to spread the meals out through the day. Okay. Adequate, good quality sleep, as I've said, is very important. I talked about sleep apnea earlier on. For a diagnosis of sleep apnea, you would need to be seen by a sleep physician. Unfortunately, we do not have a sleep doctor in Kadlec. There are several community doctors who deal with sleep apnea and central sleep apnea. One thing to note is that sleep apnea is actually more common in patients who have underlying heart disease and lung disease. And so if you have known lung disease and your partner notices that you're stopping breathing at night or snoring more, it's important to get screened for it. And the good thing is if you get screened and they don't see sleep apnea, then that's it. You don't have to undergo any further workup unless you gain 60 pounds in like a year, then that's another issue. Insomnia, I know and I understand, is a very big issue in our age group here. There are certain things that I've listed down to hopefully help relieve insomnia, apart from taking a sleeping pill. So one would be set a regular time to go to bed. Okay, so, I'm sorry, sir. Yes, sir.
How do diuretics harm the kidneys?
The question is, how do diuretics harm the kidneys? So every drug out there is a double-edged sword, right? And so when you're on diuretics and you're taking too much diuretic in that you become too dry, meaning the amount of fluid in your body is lower than what is expected, that actually stresses the kidneys and make you go into having kidney failure. So it's always important to have a good balance of everything. So if you're getting diuresis too much, then that's bad too. And a lot of the times you can feel it. If you're thirstier than normal, if your legs have already shriveled up and yet you're on diuretics twice a day, then maybe it's time to just call the doctor and ask whether or not you should continue taking the diuretic at the same dose. Yes, ma'am.
Can you recommend a website for exercising healthy lungs?
Okay, so the question is, the question is, can you recommend a website for exercising for healthy lungs? So what I would say is that any kind of exercise is good for your lungs. So any kind of exercise that you can do is okay. I always say that there's a PBS program called Sit and Be Fit in the morning. I think it's at 9 or 10 o'clock. And you can do the exercises there whether or not sitting or standing up. And that's perfectly fine. They've also studied patients who have participated in yoga at home on video. So beginning yoga or yoga for the elderly, and there is such a thing as yoga for the elderly, that is also good for your lungs. And they've actually said that yoga done at home is almost as good as pulmonary rehab in certain cases. All right, okay. So just to tie things up, going again to the topic of sleep, set a regular time to go to bed. The bed is only for sleeping. Don't eat in bed. Don't, I guess, go on the phone and argue with your friend in bed. Okay, and then you have to reduce the amount of light at night. Lower down the temperature, because I think the ideal temperature of going to bed is between 68 to 69 degrees. Lower down the temperature at night, and then avoid mental stimulation. Please turn off the television, or if you can, take the TV out of the room. And of course, I don't think you guys actually go into bed with your phones, and your iPads, right? I hope not. So turn off the iPads, turn off the phones, leave them outside. Okay. If you need a nap during the day, it's okay to nap, but make sure that they're short. And do nap towards the earlier portion of the day. And don't nap after 4 o'clock, because when 9 o'clock, 10 o'clock comes, you will not fall asleep. All right? And then limit caffeine late in the day. So the rule is not to take any form of caffeine after 3 o'clock in the afternoon. Avoid too much alcohol at night. So limit yourself to a glass, and that's it, because alcohol can actually be stimulating. Avoid refined sugar. Avoid big meals and minimize your liquids. So big meals meaning don't eat a snack, don't eat a bowl of popcorn before going to bed, okay? And liquids, because when you drink a lot at night, you'll wake up needing to go to the bathroom, because the bladder gets irritated with that. All right. So that's really is the end of my talk. Do we have time for? Yes, we do. Okay. And so if you have any questions out there. Yes, ma'am.
What do you consider limiting your naps? What kind of time limit?
So the time limit would be not longer than 2 hours during the day. So early in the afternoon, maybe max till about 2 or 3 o'clock in the afternoon. They say a good nap really are short naps. They're like good bursts of energy naps when you limit them to actually just about 30 minutes. Yes, sir?
We had a lot of smoke this past summer, and which irritated lungs. Do the lungs recover from that?
So the question is whether or not the lungs recover after it's exposed to smoke and dust. So the answer is yes. So for a person who has normal lungs and normal airways, we usually recover from the initial irritating response to smoke and dust. People who have chronic lung disease, such as COPD or asthma, may have a little bit more difficulty recovering from the acute event. You really don't get an acute injury or I would say you don't get a permanent injury in your lungs when you're exposed to that kind of pollution. You will mostly get an acute inflammation of the lungs, which then recover after you remove yourself from that exposure. Okay. Yes, ma'am.
I've been hearing a lot about the stem cell with COPD. Is that really viable?
So the question is about stem cells and whether or not it's a viable option for people who have COPD. And I will be honest with the audience here, the answer is no. It is not FDA approved. There are no studies regarding stem cells and chronic obstructive pulmonary disease. The one thing that I'm really leery of is these outfits actually ask for cash. You have to give between $10,000 to $25,000 to get treatment. And they essentially say you're going to get cured of your COPD or whatever chronic disease you have, and to me, unfortunately, there really is no magic medication for COPD. There are tons of research going on about stem cells, and there is research about stem cells and pulmonary fibrosis, but not really COPD. And so maybe in the future we will find evidence, good hard evidence that it works, and FDA will approve it, and your insurance will pay for it, and then I will say, okay, yes, I will prescribe stem cell therapy. But right now, with the amount of data that we have, it really is a dubious operation.